Hi, everyone. Good afternoon. Nice to see all of you. Thank you for joining. I am Mo Mhatre. I'm a maternal fetal medicine specialist at Tufts Medical Center in Boston and the director of the MFM Fellowship at Tufts. Really excited to share the AJOG MFM highlights this month with the editor-in-chief of the Pink Journal, Dr. Vincenzo Berghella. Vincenzo, nice to see you.
Good to see you, Mo. It's so good to have this session again. I just wanted to highlight something before we go to the highlights, so to speak. We have great news in terms of our impact factor, which was released by Clarivate last month. So we went up 16%, which is great. It's a testament to our authors, our editors, you, everybody that contributes to the Pink Journal. We had a great impact factor of 3.1 last year, and this year is 3.6. That really puts us for OBGYN journals, and there are over 100, but especially for those that publish original research like we do and like we're highlighting today, put us really in the top 10 of those journals, and really of the ones that do MFM only, the top journals. So I can't thank enough the authors, the researchers, all the community at the Pink Journal. Great work, and something to celebrate.
Congratulations. And yes, thank you to everyone for contributing such outstanding work. We're going to highlight some of that work today. For those of you who are unfamiliar with our format, we select 4 articles that we want to highlight from this past month's issue. This is July 2026 that we're going to highlight today. We're choosing articles that have topics that are relevant to people caring for pregnant patients in the office or on the labor and delivery. We try to pick those rigorous study design or interesting questions. And we really want to have highlight articles that are going to contribute and improve the care of patients, not just from those cared by our MFM colleagues, but also can help our community providers, OBGYN generalists, family medicine doctors, nurse practitioners, PAs, midwives, everyone who's caring for pregnant patients. So we are doing a high-level overview with visual abstracts that are either submitted by the authors or that I created myself, but we highly encourage you to read the articles in detail on ajogmfm.org. And with that, Vincenzo, why don't you start with the first one?
Yeah, the first one is a great idea from Dr. Jeremy and my good friend Patrick Wurtenberg from France. They talked about the risk of postpartum hemorrhage according to ultrasound measurement of the lower urinary segment. And this particular study is for women trying TOLAC, people that have a prior cesarean delivery. Dr. Rosenberg is really dedicating his whole academic life to this. They wanted to see if the thickness of the lower urinary segment late into the third trimester was associated with postpartum hemorrhage. They did a secondary analysis of the famous trial, so it's randomized data, patient data, and basically the findings. They found that the median lower urinary segment thickness was 5 millimeters, and actually the thicker it was, the less postpartum hemorrhage there was, which by itself I think is the main message of this study, and interesting, and I hope it generates more research, because how interesting it would be that if we can predict a little bit better who will have a postpartum hemorrhage and who will not. Some of the results were also more interesting and maybe contradictory. A thicker lower urinary segment was inversely associated with postpartum hemorrhage secondary to atony, and didn't find a relationship within the thickness and retained placenta postpartum hemorrhage. So again, more data needed, more research, but I thought it was an important study to present for the novelty. We don't look at the lower urinary segment that much. It does predict, we know from their data and other data, it does predict uterine rupture, for example, if you're trying a TOLAC. But now we can also see if it predicts postpartum hemorrhage.
Excellent. Some interesting work, and I think we'll jumpstart some new research too in this direction. The second paper is from our colleagues in Michigan. They were evaluating interventions that are given to live-born infants who are born at 22 weeks. So We know in general there's a national trend lowering the threshold for when interventions are given. And, historically it was 24 weeks, but the periviable period we know starts earlier. And a number of tertiary care centers across the United States are starting to offer intervention and attempted neonatal resuscitation at 22 to 23 weeks with shared decision-making with the patient. And this group wanted to try to evaluate a little bit more clearly or define, how many interventions does actually affects survival rate at 1 year, and is there a particular intervention that impacts that chance the most? So this was looking at national birth data across the United States of singleton, non-anomalous 22-weekers who were live born from 2019 to 2022, so pretty recent data. And of the 5,000 infants who were delivered, about 2,700 actually received some kind of intervention. And then they kind of found that, of the interventions, which included, assisted ventilation, NICU admission, cesarean, steroids, antibiotics after birth, or surfactant therapy, the number of interventions that an infant received, naturally that was also increasing the chance of survival at 1 year. So compared to one treatment, those who got 2 to 3 interventions had a 36% reduction in death, and more than 4 or 4 more had a 59% reduction in death at 1 year. They found that a number of these factors that I had mentioned had independently and significantly improved survival. A couple limitations of this study is that they don't have any data for after 1 year. So we know that there's a lot of potential long-term morbidity in babies who are born this early. And I think this is an important thing to keep in mind, but certainly may be different at different institutions or in different regions. So I think more data to come. I think the other interesting thing about this is that regardless of the number of interventions, the rate of survival increased every year in the study period, which I think also reflects how our neonatology colleagues are getting better at survival in general for this gestational age. So I think, there's clearly some dose-dependent response, though there might be a lot of variability in protocols and practices across institutions, but very interesting insight into what I suspect we'll learn about in the years to come.
Yeah, this goes back to, those tables that they have at AJOG, consider this, recommend this, don't do that, and I think with newer data, it looks like at 22 weeks, if we share the decision making, the patient wants quote unquote aggressive management, it sounds like, the more of the proven interventions, that are offered and given, the better the baby does. So it's important for counseling and can be used today, for clinicians. So important data.
Yeah, and the last thing I would mention is that they did find the cesarean delivery changed the chance, but we do know that, it's not recommended at this time for all infants at 22 weeks, particularly cephalic fetuses. So there's a lot more discussion in the article that I encourage everyone to read, but it was an association that they found.
The next one is about childhood maltreatment and pregnancy-related reproductive health in middle adulthood. A topic that is really near and dear to my heart, and it's so important. I'm so grateful to these authors to submit this important papers to us. We know, and I always talk about, being a parent is the most important and most difficult job, most rewarding, but with the most impact. And again, childhood maltreatment in this study, prospective studies with a 30-year follow-up, was associated later on, with this maltreated babies eventually having pregnancies with low birth weight, more gravidity, but less parties, so maybe more miscarriage or abortions. And in the childhood sexual abuse group, more infertility and a good thing, more engagement in breastfeeding. And again, poor glycemic control attenuated some of these findings. I just wanted to bring this up. We all study different issues in pregnancy, small first gestational age, FGR, preterm birth, etc. And, some of it may have its roots really in our mother's in utero life and early life, like in childhood. And we really need to make sure to have pregnancy outcome that, the person is well treated and all along, and, an opportunity to intervene, early to improve not only the person's life or herself, but also, future generations. So really important work.
And the last study I wanted to share is from our colleagues in Italy. This is looking at maternal and perinatal outcomes of pregnancy in patients with cardiac disease, classified by the modified WHO classification. And so we know that there's been a number of different classifications for cardiac disease, both congenital and acquired cardiac disease. And it can be challenging to kind of sift through the various classification systems and try to determine someone's risk. And the modified WHO classification classifies a number of conditions based on the degree of severity and the type of lesion to determine their cardiac follow-up. But also this group wanted to say, well, can we loop that in and determine what is the chance for adverse outcomes on the pregnant patient, the neonate, and the pregnancy as a whole. And so this was a systematic review and meta-analysis of 32 studies that included over 95,000 pregnancies, ranging from class 1 to class 4 of the modified WHO system. And they found a significant rise in cardiac adverse events from 2.9% in class 1 to almost 50% in class 4. The death rate also increased from 0.1% to 7.3%. And there was an increased rate of ICU admissions, arrhythmias, and edema. We also saw increased rates of adverse obstetric outcomes like FGR, preterm birth, stillbirth, and NICU admission. And also, as we know in the neonates, an increased rate of congenital heart disease, which can be familial. Interestingly, they found a decreased rate of hypertension disorders as the class worsened. And, the authors, this is obviously counterintuitive since it usually goes hand in hand with cardiac disease, but the authors hypothesized that this might be because the patients are on beta blockers or other medications that might be masking this, or that there are other factors in the more severely ill patients that are maybe affecting what's going on more than just hypertensive disorders of pregnancy. And so we're kind of losing that effect as seen. But I think this is a really nice study to kind of put it all together for you when you're seeing a patient in the office. You determine their class by the WHO criteria. And with that, you can correspondingly counsel them about what might be maternal, obstetric, and neonatal risks that they have to watch for. And I really think this was a nice way to summarize quite elegantly the impact that these various conditions can cause to the patient.
Thank you, Mo. I guess we're all done. Happy summer, everyone. And I guess we'll see everybody in August. Mo?
Take care, everyone. Have a great day. Thanks for joining.
Bye-bye.